My topic is the treatment of self-harm behaviors in adolescents. We use medicine or physiotherapy. As we know, the suicide and self-harm is a hot topic and not in China, maybe in the world. And so this maybe the conceptions before. If we study a behavior, we must give a clear conceptions. So first, I introduce this. The suicide-related behavior, including suicide ideations. That means somebody thoughts about wanting to be dead, but he don't give some behaviors. The second is suicide attempt. That means self-injurious behaviors accompanied by explained to inferred intent to die. The second is suicide death. That means complete suicide. So another word, NSSS, means now suicide self-injuries is very popular in China psychiatric clinic. It means somebody do the self-injurious behaviors without intent to die. The NSSI is included the DSM-5 in 2013 as a condition for further study. So the suicide attempt and NSSI both means self-harm. The difference is suicide attempt not was with intent to die, but NSSI is without intent to die. So in China, there are two studies. One is the study from the Professor Kwang Li's group. They investigated over 20,000 middle school students, showed the 26% experienced transient suicide ideations, and 2.23 had serious suicide ideations, and more than 1%, nearly 1.5% had attempted suicide. The suicide tendencies were associated with depression. That means the depression is the risk of suicide in the middle school students. Another meta-analysis including 62 studies, that's all from China. The prevalence of NSSI among non-clinical sample of adolescents is 22. And repetitive NSSI was more common than episode NSSI. So this number is very high in the youngs. So this is some risk factors about the self-harm and suicide in adolescents. So they include genetics and factors and personality factors, and also including the negative life events or social problems. So these risk factors maybe have get some suicide additions. So when exposure to a suicide or self-harms, they maybe do some behaviors. So the difference between suicide and self-harm is the method likely to less or not. So this is a recently meta-analysis, also published from China. Professor Chen Rensheng, he summarized the risk factors of NSSI from biopsychosocial ecological framework, also including some community-level risk factors, family-level risk factors, or the psychological risk factors or biological risk factors. So this is very comprehensive. In our group, we also do some risk analysis about, in the school students. We found we found the childhood mental treatment, academic pressure, or bullying are important risk factors for self-harm behaviors. When the emotion samples such as anxiety and depression play a mediating role between negative experience and self-harm behaviors. So, but in fact, the help thinking in the adolescents for the suicide or self-harm is very low. This data shows less than 15% of adolescents who had self-harm sought medical treatment from the hospital for their self-injuries in the UK. In Norway, they found only 34 of the young people thought they have the professional help, and 15 to 25 of adolescents treated at the hospital for self-harm when they return to the treatment of self-harm again within 1 year. This is a history of the notable self-harm intervention techniques. So we know from the beginning of the 20th century, there are many social outbreak and large-scale crisis interventions and psychodynamic therapies and prefrontal lobotomy and ECT-related approaches. Then you have the gatekeeper training and institution programs and pharmacotherapy in the 1950s till today. Then the acute psychiatry hospitalization and checking program, and the cognitive and behavioral approaches. Now we have many and another means safety and restoration and metal electric approaches. So when we are to go, this is an interview about the intervention effect published in 2020. The results showed overall intervention effect was small across all outcomes. The numbers of RCTs increased exponentially across 5 cases, but the intervention effectiveness had not improved. All intervention types produced small effects, and no intervention was significantly and consistently stronger than any others. So when we are the interventions to go, we use the medicine or psychotherapy or physiotherapy. So first, we read the next guidelines. The next guidelines is from the United Kingdom in the self-harm assessment management and preventing recurrent chapter. They say when we deal with the self-harms, the first considered may be DBTA, and the healthcare staff should be trained and supervised and work collaboration with the persons, developing a self-plan. So we do not use diagnosis, age, or coexisting conditions as reason to withhold psychological interventions for self-harm, do not offer drug treatment as a special interventions. So the next guideline emphasizes not use the drugs for the self-harm. First, he encouraged the use of psychological intervention. Many psychological psychotherapy method was suggested. The most important, most evidence is the DBT or no, then the CBT, MBBT, FT, and BF. There are many RCT report about the psychotherapy. Our team also used the life scale training for the self-harm adolescents. They show many helpful for the young. This training can reduce the hostility, anger, depression, anxiety, and blood pressures. So the Professor Williams from Duke University, he summarized the life scale into 10 scales. That means being aware, making a decision, deflection, problem solving, and so on. So our group, one of my students get a study recently published in BMC Nursing. We focused on how the psychiatric nurses working with non-suicide self-injury adolescents. So we found many challenges for the psychiatric nursing. They have internal changes. That means lacking the knowledge and the skills, feeling hard and stressful, because they don't have enough knowledge about the psychotherapy. The external barriers, including unrealistic high patients from family and schools, and cooperative patients, little help from school and communities. So another question is medicine. The medicine as a second line opening, only used in the case of comorbidity of psychiatric disorders or several self-harm behaviors. So the opinion of medicine, including SSRIs, and typical antipsychotics, more disabilities such as lithium salt, and ketamine. Current guidelines do not report evidence of this effect for psychotherapy drugs on the occurrence of self-harm behaviors. This is a meta-analysis published in 2020. They show that when the patient uses the RSS admitted in the hospital, before 1 week before, maybe the suicide or self-harm is highest. Then the line is in the hospital. After the line in the hospital, the suicide and self-harm at the same levels until 12th week later. Maybe after 12th week later, the suicide or maybe slowly down. So in the acute, the SRI may be not useful for the suicide or self-harm intervention. This is another study. He studied used the SRI on the young people. You can see for the 6 to 17 years, the blue line means use the SRI. The red line is not use the SSI. So in the 6 to 17 or 18 to 24, the use the SRA may be increase the risk of the suicide or self-harm. But after 25 years, so the SRA maybe not affect the suicide, or maybe the low suicide or self-harm. So increased suicide behavior risk among individuals under age 25 reflects the evidence from RCTs. That's the conclusion. So ketamine, yes, ketamine is very hot topic in the depression or suicide. Many studies show ketamine functions as a rapidly acting antidepressant in adolescents. A case report suggests that ketamine may be also reduce suicide addiction, but the exciting studies are small, and more research is needed to certify these findings. So, how in a long time did the ketamine work, or the work can reduce the suicide is need further study. This is a summary of the medication, the SSS, the advantages and risks. The SSRI and SNRI maybe increase the risks of self-injury and suicide. The second general psychotropic may be unclear effect dosage for aggression. Maybe other side effects, including excessive sedation or another opinion, maybe abuse, other ketamine abuse or limited duration, or NAC. NAC is also another study point, but it is not a drug. It's the adjunctive medication. So this another meta-analysis summarizes the medicine use on the NSSI or self-harm in the children and adolescents. So no statistically significant difference in the occurrence of NSSI between the SSRI and the control groups. NSSRI rate increase in depressed adolescents receiving benzodiazepine or trazodone treatment. NSSI increase in ADHD adolescents treated with stimulants such as methamphetamines, with the high stress of taking atomoxetine and amphetamines. There is limited research on other psychotropic drugs, such as the motor stabilizers and so on. So the third question is the physiotherapy. So we know the physiotherapy including the RTMS, ECT or MECT, and the TDCS and DBS. The RTMS is most popular. Some study shows the RTMS had a good clinical efficacy in treating depression. RTMS can activate and the dorsolateral prefrontal cortex of the brain and have therapy effects on depression. There have been studies on RTMS for the treatment of SSS in adolescents depression. The higher frequency RTMS at the left dorsolateral prefrontal cortex as an adjunct for antidepressant medication is promising in reduced suicide behavior in treatment-resistant depression. So there's a summary from China, use the RTMS to treatment the depression or the suicide behavior. Most of the study shows the 1-HZ may be helpful for self-harm behaviors. Then the MACT. The MACT some studies shows some studies suggest no significant improvement or only short-term improvement in adolescents with NSI. Another is DBS. The DBS is in several opinions can cause significant damage. Researchers have mostly focused on self-harm caused by only focused on the autism. Because the DBS is damage to the brain, so only the study only try in the autism spectrum disorders. Another is the TDCS. TDCS compared with other neurostimulation methods, TDCS changes the excitability of the entire tissue, so it may be more appropriately considered as a neuroregulation. The application of TDS is to reduce the behavioral impulsivity and cognitive impulsivity. If behavior and cognitive impulse are associated with the risk of self-harm, then TDS will be a potential effective way to intervene. So many studies focus on the TDCS for the young, for self-harm or depression. So our studies, our group maybe do RCT, a small sample of RCT TDS for the self-harm, including 15 patients. After 2 weeks TDCS, we found after the treatment, the brain regions of the suicide-related regions have improved. So finally, there is a flow of targets and methods of suicide prevention published in 2020. Here have maybe give some suggestions for the clinicals how to deal with the self-harm, including in acute intoxication, maybe awareness and education for the general populations, how to reduce the self-harm addictions, or how to training to the gatekeepers to prevent risk behavior. So if the youngs have the suicide addiction, so you'll be the screen of individuals at high risk. If they have a high risk, you have available some treatment for the patients, including the pharmacotherapy or psychotherapy inverse, CB, this C1 is the pharmacotherapy. Then the brain stimulation, C3, or C5, score-based emotions, or C6, internet-based emotions. Then follow up. So how to deal with this problem for suicide and self-harm, even for the general population. So we have two ongoing cohort study. One is the community-based study about in the general population. This study was supported by the China government. We just published the protocols. We will including 100,000, at least 100,000 people in a study, and at least 5 years follow-up. Another cohort study in our group is in the adolescents depression. We follow the adolescents with NSSI or suicide attempts. We collected the clinical characters, MRI, ERP, and fitness, or other metrics. Then we follow up how to reduce the suicide idea or self-harm. I think maybe later we can share our result. That's all. Thank you.